Chapter 8, Patient Assessment. Look on page 260. You'll see a chart or a graphic showing the patient assessment process. The video we just completed was Scene Size Up. This reading will be about the primary assessment and begin on page 261 and finish at 265. Let's get started. Primary assessment. During the scene size up, you use dispatch information and your own evaluation of the scene to begin determining what happened. You also evaluated potential actual scene hazards and threats, protected yourself and your team, and decided whether you needed additional resources. These steps are critical in the initiation of patient care. Patient assessment, however, begins when you greet your patient. The primary assessment has a single, critical, all-important goal. A single, critical, all-important goal: to identify and initiate treatment of immediate or potential life threats. The patient's vital signs, level of consciousness, airway, breathing, and circulation, the ABCs, will determine the extent of your treatment at the scene. Vital signs are the key signs that are used to evaluate the patient's condition. Always give priority to the patient's level of consciousness and ABCs to ensure life-saving treatment. Look at figure 8.7. From here, you will be able to determine the priority of patient care and transport.
Form a general impression.
Anytime you meet someone new, you form an initial impression. You form an initial general impression about that person. Forming an initial general impression of your patient is a similar process, but it helps you focus your attention toward life-threatening problems. The initial general impression is formed to determine the priority of care and is based on your immediate assessment of the patient. This includes noting things such as the patient's age, sex, race, level of distress, and overall appearance. You may anticipate different problems depending on the patient's age, sex, and race. A woman reporting abdominal pain, for example, may have more serious implications than a man with the same complaints because of the complexity of the female reproductive system. Write any important information down because it will be difficult to remember minor details later. You should think of your initial general impression as a visual assessment, gathering information as you approach the patient. As you approach, make sure that the patient sees you coming to avoid surprising the patient or causing the patient to turn to see you, possibly making any injuries worse. Note the patient's position and whether the patient is moving or still. When you reach your patient, place yourself at a lower position, if possible, to show respect for the patient and help the patient feel comfortable and less threatened as you begin your assessment. See figure 8.8. Refer to the patient by name. The initial general impression continues during your introduction. Introduce yourself to the patient by saying, "Hi, I am Sam, an EMT with the fire department, and I am here to help you." Is the patient able to respond to your greeting easily and appropriately? The patient's response can give you insight into the level of consciousness, airway patency, and respiratory status before you begin your examination. After you introduce yourself, you should ask the patient about the chief complaint. Assess the patient's skin color and condition as you begin. For example, is the patient's skin pink, pale, gray, or cyanotic? Is it dry, clammy, or diaphoretic? The patient may direct you to a wound on his or her leg or demonstrate an airway problem by creating abnormal sounds when breathing. If a life-threatening problem is found, it should be treated immediately. Determine whether your patient's condition is stable but potentially unstable, or just unstable. Page 262.
Assess level of consciousness.
The patient's level of consciousness, or LOC, is considered a vital sign because it can tell a great deal about the patient's neurologic and physiologic status. The brain requires a constant supply of oxygen and glucose to function properly. In the primary assessment, you need to ascertain only the gross LOC, level of consciousness, by determining which of the following categories best fits your patient. Conscious with an unaltered LOC, conscious with an altered LOC, or unconscious. Let me do those again. Conscious with an unaltered LOC, conscious with an altered LOC, or unconscious. When a patient is conscious with an altered LOC, it may indicate that inadequate perfusion and oxygenation or a chemical or neurologic problem is adversely affecting the brain and its ability to function. Perfusion is the circulation of blood within an organ or tissue. An altered LOC in a conscious patient can also be caused by medications, drugs, alcohol, or poisoning. Your assessment of a patient who is unconscious should focus initially on problems with airway, breathing, and circulation. That's problems with airway, breathing, and circulation, the ABCs, which are critical life threats, and then identify other emergency care that the patient may need. Sustained unconsciousness should warn you that a critical respiratory, circulatory, or central nervous system problem or deficit may exist, and you must assume that the patient has a potentially critical injury or potentially life-threatening condition. Therefore, after rapidly assessing the patient and providing emergency treatment, you should package the patient and provide rapid transport to the hospital. When you assess a patient, you must determine the appropriateness of the patient's response by how well it demonstrates the patient's understanding and mental activity, not by how well it reflects your definition of socially acceptable behavior. Mental status and LOC can be evaluated in just a few seconds by testing for responsiveness and orientation. A test for responsiveness assesses whether the patient is alert and how well a patient responds to external stimuli, including verbal stimuli, like sound, and painful stimuli, such as pinching the patient's earlobe. One test for responsiveness uses the AVPU scale, AVPU. It uses the AVPU scale to assess how well a patient responds to stimuli. The AVPU scale is based on the following criteria. Alert. The A in AVPU means alert. The patient's eyes open spontaneously as you approach, and the patient appears to be aware of you and responsive to the environment. The patient appears to follow commands, and the eyes visually track people and objects. The responsive to verbal stimulus. V, verbal. The patient's eyes do not open spontaneously. However, the patient's eyes do open to verbal stimuli, and the patient is able to respond in some meaningful way when spoken to. That takes care of the A. That takes care of the V. Now the P, pain, responsive to pain. The patient does not respond to your questions, but moves or cries out in response to painful stimulus. There are appropriate and inappropriate methods of applying a painful stimulus, based a great deal on personal preference. See Figure 8-9. That takes care of the A, the V, and the P. Now let's take care of the U, unresponsive. Unresponsive is the U in AVPU or AVPU. The patient does not respond spontaneously or to a verbal or painful stimulus. The patients usually have no cough or gag reflex and lack the ability to protect their airway. If you are in doubt about whether a patient is truly unresponsive, assume the worst and treat appropriately. For a patient who is alert and responsive to verbal stimuli, you should next evaluate orientation. Orientation tests mental status by checking a patient's memory and thinking ability. The most common test evaluates a patient's ability to remember four things: person, place, time, and event. Person. The patient is able to remember his or her name. Place. The patient is able to identify his or her current location. Time. The patient is able to tell you the current year, month, and approximate date. Event. The patient is able to describe what happened. The MOI or NOI. The event is the mechanism of injury or nature of illness. Let me take a second here. Asking the patient who the President of the United States is does not assess orientation. These questions were not selected at random. They evaluate long-term memory, person, place, and if the patient is at home. Intermediate memory, place and time when asking your month, and short-term memory, time when asking approximate date and event. If the patient knows these facts, the patient is said to be alert and fully oriented. Alert and oriented to person, place, time, and event, or alert and oriented times 4. If a patient does not know these facts, he or she is considered less than fully oriented. Use the Glasgow Coma Scale, GCS. It can be helpful if providing additional information on patients with changes in mental status. The GCS, discussed further in Chapter 15, Neurologic Emergencies, uses parameters that test a patient's eye opening, best verbal response, and best motor response, which provide a numeric score that defines the severity of a patient's brain dysfunction. See Table 8.1 for more on the GCS. Moving on, page 264. When you are reporting the GCS score, you should document or report each section. Example, eye opening, 3. Verbal response, 4. Motor response, 5, equals GCS score of 12, to document baseline function in each area. Pupils. The diameter and reactivity to light of the patient's pupils reflect the status of the brain's perfusion, oxygenation, and condition. The pupil is a circular opening in the center of the pigmented iris of the eye. The pupils are normally round and of approximately equal size and serve as optical diaphragms. Adjusting their size depending on the available light. In normal room light, the pupil appears to be mid-size. With less light, the pupils dilate, allowing more light to enter the eye, making it possible to see even in dim light. With high light levels, or when a bright light is suddenly introduced, the pupils instantly constrict, allowing less light to enter, protecting the sensitive receptors in the inner eye from damage. See Figure 8.10a. When a brighter light is introduced into one eye, or higher levels of light enter one eye only, both pupils should constrict equally to the appropriate size for the pupil receiving the most light. I'm going to repeat that again. When a brighter light is introduced into one eye, or higher levels of light enter one eye only, both pupils should constrict equally to the appropriate size for the pupil receiving the most light. In the absence of any light, the pupils will become fully relaxed and dilated. See Figure 8.10b. When light is introduced, each eye sends sensory signals to the brain indicating the level of light it is receiving. Pupil size is regulated by a series of continuous motor commands that the brain automatically sends through the oculomotor nerves to each eye, causing both pupils to constrict to the same appropriate size. Normally, pupil size changes instantly to any change in light level. A small number of the population exhibit unequal pupils. If the patient or family member cannot confirm the presence of this condition, you must assume the patient has depressed brain function as a result of central nervous system depression or injury if the pupils react in any of the following ways. If they become fixed with no reaction to light, They dilate with introduction of a bright light and constrict when the light is removed. React sluggishly instead of briskly. Become unequal in size, like in figure 810C. Become unequal in size when a bright light is introduced into or removed from the eye. Depressed brain function can be caused by the following situations: injury of the brain or the brain stem, trauma or stroke, brain tumor, inadequate oxygenation or perfusion, drugs or toxins, central nervous system depressants, opiates, which are one category of central nervous system depressants, cause the pupils to constrict so significantly, regardless of light, that they become so small as to be described as pinpoint. Intracranial pressure from intracranial bleeding may cause sufficient pressure against the oculomotor nerve on one side that the motor commands can no longer pass from the brain to that eye. When this occurs, the eye no longer receives commands to constrict, and its pupil becomes fully dilated and fixed. This is described as a blown pupil. The letters P-E-A-R-R-L, or Pearl, the letters P-E-A-R-R-L, serve as a useful guide to assessing the pupils. They stand for the following: P, pupils, E, equal, A, and, R, round, R, regular in size, L, react to light. Again, P, pupils, E, equal, A, and, R, round, R, regular in size, L, react to light. For patients with normal pupils, you can report pupils are equal and round, regular in size, and react properly to light. The pupils equal P-E-A-R-R-L. Describe any abnormal finding using the longer form, such as pupils are equal and round. The left pupil is fixed and dilated. The right pupil is regular in size and reacts to light. Assess the airway. As you move through the steps of the primary assessment, you must always be alert for signs of airway obstruction. Regardless of the cause, a mild or severe airway obstruction will result in inadequate or absent airflow into and out of the lungs. To prevent permanent damage to the brain, heart, and lungs, or even death, you must determine if the airway is open, patent, and adequate. Responsive patients. Patients of any age who are talking or crying have an open airway. However, watching and listening to how patients speak, particularly patients with respiratory problems, may provide important clues about the adequacy of their airway and the status of their breathing. For example, sounds of stridor. That word is stridor. A brassy crowing sound prominent on inspiration. Suggest a mildly occluded airway caused by swelling. High-pitched crowing sounds may indicate a mild airway obstruction from a foreign body. A conscious patient who cannot speak or cry most likely has a severe airway obstruction. If you identify an airway problem, stop the assessment process and obtain a patent airway. This may be as simple as positioning the patient so the air moves in and out, suctioning liquids from the airway, or removing an obvious foreign object from the patient's mouth. It may be as complex as abdominal thrusts to remove the foreign body from the airway. Although airway and breathing problems are not the same, their signs and symptoms often overlap. If your patient has signs of difficulty breathing or is not breathing, you should immediately take corrective actions using appropriate airway management techniques. Unresponsive patients. With an unresponsive patient or a patient with a decreased level of consciousness, you should immediately assess the patency of the airway. Responsive patients should be considered to have experienced a traumatic event. If there is a potential for trauma, use the modified jaw thrust technique to open the airway. That concludes this video. We will pick up on the next video on page 266. We have left off on page 265. Take a minute and read the "You Are the Provider."